in the molecular biomarker era, where we're understanding that lung cancer is really divided between different biomarker subsets, many of which are tied to specific therapies. And so currently, this is the landscape of actionable biomarkers in patients with advanced non-small cell lung cancer that are tied to specific FDA-approved therapies that we really should be testing for all our patients. So on the left, these are all the genomic molecular alterations, and then the right are IHC-based biomarkers. In addition, now we also have actionable biomarkers in the early stage setting as well that are being increasingly used to guide perioperative treatments. And so what this tells us is that comprehensive biomarker testing with broad panel NGS and IHC is really important for our patients in lung cancer. And so today we're going to focus on HER2, specifically the mutations and the overexpression as oncogenic biomarkers in non-small cell lung cancer. So let's talk a little bit more about the underlying biology. So HER2 protein is a receptor tyrosine kinase that's encoded by the ERBB2 gene in chromosome 17. And so the HER2 is actually the protein, and then ERBB2 is the gene. However, having said that, the term HER2 can still be broadly applied to refer to the gene as well. So you will see that used interchangeably. And so in terms of the structure, you have the extracellular domain on the top, you have trans or juxtamembrane domain in the middle, and then you have the tyrosine kinase domain, or the TKD, which is the main engine of the protein. And so in normal cells, when you have ligands that bind to the HER family receptor, that leads to dimerization with HER2, which leads to downstream signaling pathways to be activated that are important for survival and proliferation. And now in HER2-driven lung cancer, you can have specific mutations in ERBB2 gene, most commonly in the TKD region, that basically turns on HER2 constitutively and leads to overactivation of HER2. You can also have increased copies of ERBB2 gene that can lead to increased expression of HER2 receptors on the surface, which also leads to increased HER2 signaling. And so based on these mechanisms, the ERBB2 gene mutations, ERBB2 gene amplification, and HER2 overexpression are important oncogenic biomarkers in lung cancer, and we'll discuss each of them in great detail. So starting off with activating ERBB2 mutations in lung cancer, again, these are mutations that turn on the HER2 protein. And so there are three main types. So the first one are the TKD mutations, and this is the vast majority, up to 60% of mutations. And the most common and the most important one to remember are the exon 20 insertions. Most commonly the insertion YVMA variant, but there are also a lot of other exon 20 insertions that occur at a sort of a lower frequency but are important for diagnostics. And then we also have trans or juxtamembrane domain mutations as well as extracellular domain mutations that occur at a smaller frequency. Now, ERBB2 mutations in general occur in about 3% of patients with non-small cell lung cancer and are typically seen in patients with adenocarcinoma histology, those with never light smoking history, as well as Asian heritage and female sex. Now, having said that, though, it's important to remember that these mutations can occur in patients lacking these classic characteristics. So it's really important that we're testing all patients with advanced non-small cell lung cancer for HER2. So quickly going over ERBB2 amplification, again, de novo ERBB2 amplification can be seen in up to 5% of lung cancers, but high level of amplification is actually pretty rare, seen in a subset of 1%. In contrast to the mutations, these are actually associated with male sex and positive smoking exposure. And these can also be seen as a bypass mechanism for acquired resistance to different types of targeted therapies, including osimertinib, and can be seen in about 3 to 10% of cases. Now, talking about HER2 expression in lung cancer, so here we're using IHC or immunohistochemistry to measure the intensity of membranous staining in the tumor cells, going from 0 to 3+, 3+ being the highest level of expression. So HER2 overexpression of 2 to 3+ is a known poor prognostic factor that can be seen in up to 20%, but 3+, again, the highest level of expression is seen in a smaller subset of 2 to 6%. And interestingly, these can actually coexist with other drivers and are not mutually exclusive, and the expression can be dynamic and change with treatment. And so the next question we can ask is, is the IHC, are they correlate with other biomarkers that we talked about? And so in terms of the amplification and overexpression, so most cases with high level amplification is going to have 3+ staining, but the reverse is not true. So not all cases with 3+ are going to have an underlying amplification. And these mutations and amplification are now correlated in terms with the mutations. And so what this tells us is that these HER2 biomarkers, despite the fact that they're all HER2, are really distinct biomarkers that require a very unique and specific diagnostic approach. So, now we talked about HER2 and why are these biomarkers important in patients with lung cancer? And Dr. Lee is going to go into greater detail about all the therapeutic data, but I just wanted to give a very high-level overview of why we need to be testing our patients for HER2. And so starting off with activating HER2 mutations, now we have 2 TKIs, zongertinib and cevavertinib, that are approved in the second-line setting for patients specifically with TKD activating mutations. And then we also have TDXD that is approved in the second-line setting as well for patients with a little bit of a broader sort of indication label, which is all activating mutations. And so these mutations are now a clinical-grade biomarker that's included in the NCCN guidelines and should be tested preferably using a broad panel. HER2 amplification is still, there's still no approved therapy, so this remains investigational. And then for overexpression, TDXD is actually approved for patients with advanced HER2 positive 3+ IHC solid tumors, including lung cancer in a second-line setting. So again, this is also another clinical biomarker that is recommended by the NCCN guidelines for testing using specifically IHC. And so now we talked about why we need to be testing for our patients. Now let's talk about different assays that we can use to actually implement testing in the clinic. And so today we're going to focus on mutations and overexpression because those are the ones with FDA approvals. And so starting with the HER2 mutations, there are 2 different approaches that we can take. So first we can use a PCR-based hotspot assay. And so these are really for detection of known most common mutations like the exon 20 insertions, most common variants. So this is fairly rapid. There's less DNA requirements. It's very sensitive. But the big limitation here is that it does not detect all or novel variants. And so you can actually potentially miss some of the exon 20 insertions that are actionable using PCR. And then of course we have next generation sequencing or NGS, which takes a little bit more time, it's more expensive, requires more infrastructure and more DNA. But the big advantage here is that it can genotype and sequence all HER2 mutations that are activating and actionable. So this is really the preferred method if there's enough tissue. So another point that I wanted to really highlight here today is that not all HER2 mutations that we detect in our NGS and we see in our report are actually activating or actionable. And so to demonstrate this point, here we have this plot showing all the HER2 mutations from NGS that were reported in a molecular database in patients with advanced non-small cell lung cancer. And so each dot represents basically one mutation that's detected across the gene, and then with these peaks represent multiple mutations. And so, but when we actually filter these mutations for only the ones that are activating, then, again, these are the 3 main subtypes that we talked about. Only about half of the HER2 mutations remain. And so what this tells us is that, just detecting them is just half the battle. We need to understand when we see a mutation, whether it's activating and actionable. And so how do we go about in doing that, right? So there are several strategies that we can take. So one thing we can do is actually just look for the hotspot mutations that we know are recurrent. And so these include things like the exon 20 insertions that we talked about, but also some of the rare but recurrent mutations. And another interesting point is that I think we also need to differentiate whether the activating mutation is in the TKD or the not TKD, which is in the exons 18 to 24, given some of the differences and the nuances in the drug approvals. And I also highly recommend everyone to use some of these somatic variant annotation databases like OncoKB, which is actually FDA recognized. It's very up-to-date, easy to use, and can tell you all the answers essentially. And then, always consult a molecular pathologist if there's any question. And I just wanted to highlight that, all molecular reports these days should actually have the annotation data available in the report, so you can refer to the actual molecular report, given the recent recommendations by AMP, ASCO, and CAP. And so moving on to now HER2 overexpression in lung cancer. As I mentioned before, we need a dedicated IHC screening strategy. So we need an IHC, not NGS, to detect these alterations. And actually, we need to use the HER2 guideline for gastric and GE junction cancers, because that's actually what was used for the trial that led to the approval. Not the breast guideline, which I think a lot of pathologists and oncologists are familiar with. And so there's big differences between actually these 2 guidelines. So the thing about the gastric cancer guideline is that incomplete tumor cell staining actually counts as a positive signal. And then another big difference is that there are different tumor cell requirements for biopsy versus resection. So for biopsies, there's actually a lower threshold because the possibility of undersampling. And then again, 3+ IHC is really the only actionable biomarker that we need to think about. And so currently there's no role for doing things like HER2 FISH for equivocal cases in lung cancer as a standard in breast cancer. All right, so now we talked about these assays sort of in isolation. Now let's start thinking about how we can take these assays together to build some sort of a clinical workflow that we can implement in our patients for HER2 testing. So here I'm going to talk about the 3 most common clinical scenarios that I encounter in my clinical practice and to demonstrate these points. So the first case here, we have patients with de novo treatment-naive advanced non-small cell lung cancer. Right? These patients present, initial presentation, and we need to do the full diagnostic workup. So for that, we would recommend NGS, right, if there's sufficient tissue, as well as IHC, obviously for PD-L1, but also for some of these other biomarkers like HER2 and c-Met that require IHC testing. And then we can also have patients who have advanced non-small cell lung cancer that are currently progressing on therapy. And now if the NGS has been performed previously and the HER2 status is already known, then there's really no need to repeat NGS for that sort of clinical scenario. Now if it's for resistant targeted therapies, that's a completely different story. But in this scenario, we would just do IHC to look for the overexpression. And then in patients, sometimes we see where they only did a multiplex PCR, let's say for ERBB2, and they actually did not do NGS testing. And then let's say the HER2 status was considered negative. So this is kind of our patient that we described. In that case, I would actually repeat NGS, given the known limited sensitivity of PCR, and actually repeat NGS to make sure that we're sequencing HER2 as well as doing IHC. And then our last clinical scenario is one of those situations where it's too painful even to talk about, but this happens more often than not. And so these are cases where we have scanned tissue, we need to assess for all HER2 biomarkers, but the tissue, we don't have tissue to do NGS. And so in that case, I would actually do IHC because that you need tissue for that, and then consider doing PCR. And if it's positive for HER2 mutation, then that's great. But if it's negative, then I really recommend doing repeat tissue or liquid biopsy using NGS. And so let's talk a little bit about liquid biopsy testing for our patients with HER2. So we all know that liquid biopsy using ctDNA can be really helpful for our patients with advanced stage lung cancer, especially in cases where we have insufficient tissue biopsies or situations where tissue may not be readily available. But we also have to recognize the important limitations of liquid biopsy, right? Mainly that sensitivity is extremely dependent on the disease load, stage, and ctDNA shedding, which can be highly variable even in patients with advanced stage disease. And so what happens is, if you do NGS and you find a mutation, that's great on plasma samples. But if there are no mutations detected, we really need to reflex back to tissue to make sure that we're covering for HER2 more sensitively. And of course, if IHC status is unknown, then we need to do tissue biopsy because we cannot assess for HER2 IHC on liquid biopsies. And so now let's take a little step back and talk about some of the logistical considerations for HER2 biomarker testing, and think about are we doing a great job at exploring on how to optimize biomarker testing for our patients with HER2. So here I think it really starts from the beginning where we have to make sure that we do adequate tissue procurement, and ideally this is done through incorporating rapid on-site evaluation or ROSE. And we really need to make sure that we're doing appropriate sample preparation as well as accurate diagnosis using minimal tissue to make sure that we're conserving tissue for all the necessary biomarker testing. And then, of course, we need to initiate reflex biomarker testing. And ideally, this is, I think, done in a pathology-initiated workup involving a lot of these assays that we talked about, IHC, PCR, and NGS. And then lastly, we want to make sure we have a timely and understandable reports where the actionability is very clearly defined and treatment plan can be finalized. So we all know that this is it's easier said than done, right? This is quite complicated and there can be a lot of challenges, but I think there can also be some solutions that we can start thinking about. So one big challenge I think is that there still is a limited sort of awareness regarding HER2 biomarkers in the community. These are fairly recent approvals, right? And so I think we need to continue to raise awareness for HER2 testing through education, advocacy, and outreach through multidisciplinary collaboration within the hospital setting, as well as outside of the local hospital setting and in sort of MDT collaboration that we're doing now. And then, we also have issues with inadequate diagnostic tissue for complete biomarker testing, right? Tissue is always going to be the issue. And so for that, I, again, encourage everyone to think about incorporating ROSE, or rapid on-site evaluation, and then also optimizing your tissue strategy so that we can, do a better job in terms of tissue triaging and stewardship during diagnostic workup. And then, of course, considering liquid biopsy for the mutations in select clinical scenarios. And there still is going to be a lot of gaps, delays, and inefficiencies in biomarker testing that's in HER2, but also in other types of actionable biomarkers. And so I really do believe that pathology-initiated reflex protocol can address a lot of these problems because I think it can expand the testing rates, right? We can reduce the bias in terms of testing because we're going to test everybody. And I think it also helps to minimize turnaround time and then just increase the overall efficiency of the process when you put the pathologist in charge. And then lastly, I think there still is a lot of confusion regarding the HER2 biomarker as just the actual biomarker, but also the testing results, right? Are we talking about a mutation? Is it an overexpression? What is considered actionable? What kind of assays do we use? And so I still think we need to continue highlighting the distinct nature of HER2 mutations from HER2 overexpression. And then particularly for HER2 mutations, we need to think about what's activating or not activating, whether it's in the TKD or not TKD. And then for the overexpression, we need to really focus on that 3+ overexpression. And then, of course, we need to think about the different roles of diagnostic tests at play. So going back to our patient, right? So this is our patient with the HER2 mutation where the mutation was initially missed on PCR testing. And so here we see this HER2 exon 20 mutation, the G776 del-NSCLC. So this is actually an uncommon exon 20 insertion mutation that is actually activating the TKD, and it's within the TKD, and it's actionable. And so this, again, highlights the fact that PCR can actually miss some of these more uncommon HER2 mutations and really highlights the importance of NGS for detecting the broad and the diverse landscape of activating HER2 mutations. And so we really recommend doing NGS as part of the initial diagnostic biomarker testing panel. And even though this patient had IHC of 1+, again, I wanted to emphasize that HER2 3+ overexpression is a distinct biomarker that is now actionable and requires a separate IHC assay. And so with that, thank you for your attention, and I'll take it over. I'll lead it to Dr. Lee.
Yeah, thank you, Dr. Yang. So that was a really comprehensive discussion of the testing. So now we detected this genetic alteration, and then, like Dr. Yang was clearly stated, that this is a mutation that's in the TKD domain, is an oncogenic driver. So what we can do to serve this patient after the chemoimmunotherapy progression. So I will repeat some of the information just to emphasize that the mutation, most common TKD domain mutation is actually YVMA insertion that occurs more than 30% of the cases, but other insertions in the exon 20 still is oncogenic event. We knew about EGFR and HER2 have huge homology because they're ERBB family 1 and 2. So the effort of using small molecule to target HER2 insertion mutation has been ongoing for at least a decade. Earlier, we have agents or small molecule inhibitors that can have cross-board efficacy to all the EGFR family, including, for example, afatinib and some of the agents later on tested poziotinib. However, there are a couple of problems with this small molecule earlier setting. One is the response, as you can see, even the peritinib and the poziotinib is only at 30%, and then the duration of response or progression-free survival is quite short. So that also cannot balance the patient's toxicity on treatment with a significant diarrhea. Therefore, this list of medication was not able to get FDA approval. But we do have a different class of drug that can be used in this HER2 mutation setting. So the first approval comes from trastuzumab deruxtecan, that's a HER2 mutation lung cancer. In the initial study in DESTINY-Lung01, when the dose was offered at 6.4 milligram per kilo dose, the response, as you can see on the waterfall plot, is greater than 50%, and the majority of the patient derive benefit. So the efficacy is significantly better than the small molecules of the earlier generation. However, at that dose, for lung cancer patient, the pneumonitis rate is quite high at 26%. As pneumonitis can quickly turn into a life-threatening situation, therefore subsequent study was conducted including DESTINY-Lung02, reduced the dose to 5.4 milligrams with additional pulmonary restrictions and cautions. In the DESTINY-Lung02 study with 5.4 milligrams per kilo, the efficacy was overall maintained. The response rate is still in the 50% range, and the pneumonitis rate significantly decreased. That's also associated with our awareness of early detection of pneumonitis and early treatment with steroids. The duration of response, including PFS, is 9.9 months, and overall survival in the study is 19.5 months. DESTINY-Lung04 is the study that's evaluating frontline trastuzumab deruxtecan in comparison to chemoimmunotherapy for HER2 mutation lung cancer patients who are treatment naive. Currently, this trial has completed enrollment, and we're waiting for the readout of the study. So although we didn't have the initial wave of success with a small molecule TKI, over the years, we start to be able to create more HER2-specific EGFR-sparing TKI. Zangertinib is one of the examples, showing here that the targeting of EGFR is quite different of zangertinib versus earlier generation poziotinib. The HER2 efficacy potency is still very, very high. So BIMEAN-Lung01 is a study tested zangertinib in HER2 mutation and some other genetic alteration associated with ERBB family, and the multiple cohort was planned. So the first cohort that's reported out was at 120 milligrams once a day dosing for patients who had a prior treatment for the HER2 mutation disease. However, there's no ADC that's targeting HER2 used in the prior lines of therapy. The waterfall plot showing here has a response rate of 71%. So I also have to remind you that this is only for TKD domain patients, just like Dr. Yang was saying that for small molecule, this is particularly efficacious. And the disease control rate is as high as 96%, almost as good as some of the EGFR TKI we're using today. The median PFS is 12.4 months, and the duration of response is 14.1 months. Overall, because of the complete EGFR sparing, zangertinib's toxicity profile is really quite tolerated. We still see some form of diarrhea and skin rash. However, majority of them you can see is very low grade, as indicated by light blue. Some of them is at grade 2, but overall the toxicity profile is very easy to manage. In addition, in this initial cohort of presentation, there's no drug-related ILD. In this BIMEAN-Lung01 study, we also evaluated a few other cohorts that's quite important for clinical use. So the first one is cohort 5. That's the patient who had not just chemoimmunotherapy, but also HER2 ADC. Here, we still see a nice response rate in the 40% range, showing or highlighting that different mechanism of action, different targeted therapy, you can actually sequentially use them. Patients still derive clinical benefit. So zangertinib also reported the intracranial activity at 41%. However, this is a very small patient population. We're looking forward to additional intracranial activity report from zangertinib as well as from zivobertinib I will be talking about very soon. Last piece about the zangertinib is really exciting, as there's a cohort evaluating patients, their HER2 metastatic non-small cell lung cancer had never had treatment before. So in this report that's late last year by Dr. Sanjay Palpate, showed a response rate of 77%. As you can appreciate the waterfall plot, almost every single patient achieved the tumor reduction. Very impressive and encouraging data. We're waiting for PFS as well as DOR to mature, because at the last data cut, all the numbers are floating above 50%, really is encouraging for patients, and we're looking forward to see the data in the coming conferences. With all those information, BEAMION-Lung-02 was to evaluate zangertinib in the frontline HER2 mutation patients compared to chemoimmunotherapy. And this trial also completed the global enrollment. And in addition, zangertinib has the FDA voucher that potentially can be approved in the frontline setting before the full readout. So together with zangertinib, zivabertinib was also FDA approved for HER2 in the same year of last year, making HER2 the highlight of 2025. This is a different drug that's completely different chemistry. That's a reversible medication. Therefore, those zangertinib, zivabertinib, their resistant mechanism on target HER2 secondary mutation could be quite different. SOHO-1 is a similar design to BEAMION-Lung-01, evaluated multiple cohorts in HER2 mutation patients. This is the data we reported out also earlier last year. In zivabertinib, in previously treated patient population, response rate is as high as 64%. In addition, the PFS is 8.3 months, and duration of response is 9.2 months. Similarly, zivabertinib was also evaluated in patients who had a prior ADC treatment, and the response rate, again, is in the high 30%, very consistent with also the zangertinib data. So cohort F is the cohort of patient who had a treatment-naive HER2 mutation non-small cell lung cancer patient. Very encouraging overall response at 71%. Disease control rate is also very high. Again, data is not completely mature. Initial evaluation of duration of response is 11 months, and the progression-free survival is still not mature. We're waiting for this data to be reported out in this year as well. This is the overall toxicity profile. First thing I want to highlight is there's no interstitial lung disease or pneumonitis for zivabertinib. So both of the TKI are very safe from the pneumonitis perspective. Zivabertinib has a higher rate of diarrhea. So in the previously treated patient, especially who had prior immunotherapy, the rate can be as high as 70 to 80%. The diarrhea is very similar to all the EGFR TKI diarrhea, as is a on-target toxicity. So proactive management make a big difference so that patient can be on treatment for longer duration to have the complete clinical benefit. SOHO-2 is designed to evaluate zivabertinib in frontline HER2 setting with zivabertinib in comparison to chemoimmunotherapy. This is ongoing globally enrolling patients. I want to highlight a couple of new agents, just one slide each. Similar to EGFR mutation, HER2 mutation lung cancer have a high rate of CNS metastasis. Therefore, designing a high CNS penetrant TKI going to be very critical to continue to move the boundary forward, both on PFS as well as on OS. So Nuvalent 330 is one of the molecules currently in phase 1 testing. Very similarly, there's another HER2 selecting TKI from Iambic in clinical testing as well. So we're looking forward to see those trials report out. So now we're finishing 2025, moving towards 2026. The top landscape is still showing as of today. Currently, we're still using chemo doublet as a primary treatment option for frontline HER2 patients. But now we have 3 different targeted therapy in the second line. Very possible we'll be moving HER2 TKI as an oral option for patients into the frontline setting, and then save the ADC and the chemo, immuno, and future experimental therapy for later. So in summary, this is an exciting time for HER2 mutation non-small cell lung cancer. Now we have 3 targeted treatments, all approved, and they are all both evaluated in the frontline and the second line setting. The good news is there are 2 oral medications with very little pneumonitis risk. So we as a clinician and the patient, we need to evaluate the risk in that setting. And the newer drugs are emerging in the horizon. We're not stopping just by our current success. So for this particular case that Dr. Yang was mentioned, this is a relatively young patient. The demographics fits with HER2 mutation patients who had a non-smoking history. And then we started the patient on zivobertinib 2 milligrams a day. So the patient returned to the clinic 2 weeks after us we're doing the blood check, and the patient started to have grade 1 diarrhea. At that time, she was managed by some of the oral medication over the counter. And then later, she also returned to the clinic at a 6 weeks visit and still have the grade 1 rash. That's, again, managed by over-the-counter cream. The good news is we performed the initial CT scan, and really the patient had a nice 50% tumor reduction with improved performance status and improved overall health.
Thank you, Dr. Lee, for that wonderful summary of all the therapeutic approaches for patients with HER2 mutant lung cancer. And I wanted to kind of continue on some of those themes and talk about some resources for patients. So certainly, the diagnosis of stage 4 lung cancer is a life-changing diagnosis for any patient, not only to have to think about particular treatments, how long treatments are going to work, but side effects that come from treatments, how it impacts their life in many different ways. And from the medical side, it's really a team effort taking care of patients with advanced lung cancer. So just to continue on, our patient currently receiving cevabertinib and had a nice response, had the diarrhea, as Dr. Lee mentioned, and then rash later on after initiation of therapy. And it's important that we have other medical specialists who are available to help manage some of these side effects. So, for example, our colleagues from dermatology who can help manage skin-related side effects, either actual management or preemptive treatment strategies. Pulmonary physicians to help diagnose management of pneumonitis, which can be seen with the trastuzumab deruxtecan. And of course, our supportive care specialists for pain management and psychosocial support that's often necessary dealing with the diagnosis of advanced lung cancer. So my own institution, we actually have a whole program on skin toxicities from anti-cancer therapies that's managed and run by a cutaneous oncology group and by dermatologists. And the typical rash management are topical steroids, such as low-potency steroids, topical antibiotics, clindamycin lotion, sometimes oral antibiotics and tetracycline-based antibiotics like doxycycline have been very successful here. I think it's important also to counsel patients about sun sensitivity and to apply sunscreen, as sunburns can certainly worsen the types of rash you get from the EGFR-mediated skin toxicity that you see with cevabertinib, for example, and wearing protective clothing. There are guidelines for management of pneumonitis that can be seen with trastuzumab deruxtecan. Grade 1 pneumonitis, which is a asymptomatic radiographic only finding, can be managed with either observation or with steroids. This is the only grade of pneumonitis where you could potentially retreat the patient with trastuzumab deruxtecan, and there's a publication on this looking at how frequently can patients be retreated and how, and some of the patients can redevelop pneumonitis, but others can be continued on therapy. Higher grades of pneumonitis that are symptomatic, grade 2, 3, 4, require interruption of the medication as well as more extensive corticosteroid treatment or other immunosuppressants to be used in this situation. So I think it's important to keep this in mind, and our pulmonary colleagues are also very familiar with this. And you want to, someone who has suspected interstitial lung disease typically has a workup which may include a bronchoscopy or a sputum analysis, making sure it's not a heart failure or volume overload or other things, or an active infection, as if since the treatment is immunosuppression, you would not want to necessarily do that with an active infection. So there are also patient-friendly educational resources that are available for patients, and I wanted to highlight some of them. This is one called UN Lung Cancer. It is a web-based platform developed by a Breath of Hope Lung Cancer Foundation, where it's written in patient-friendly language. There are animations. There are sections on biomarker testing and understanding what these biomarkers are all about. Here in this module, HER2, and experts who explain how HER2 mutant lung cancer is treated, and that's true for all the other biomarkers. So it's a very nice resource for patients to go and get information about lung cancer in a very patient-friendly written format. There are also other advocacy foundations, including the Exon 20 group, which focuses both on EGFR and HER2 exon 20 mutations, the TKD domain mutations, and can provide information on clinical trials, as well as general information about what is happening in this space and what kinds of new therapies are being developed. There are also more general lung cancer advocacy groups like Go-To for Lung Cancer, which can provide a wide variety of information about lung cancer screening, diagnosis, treatment, and biomarker testing, and the websites are listed below. So back to our patient, received cevabertinib, developed some side effects. The diarrhea was able to be controlled with loperamide as needed. Rash improved with topical therapies as well as intermittent doxycycline. But unfortunately, after 13 months of therapy, the patient developed disease progression. And at that point, the patient underwent a repeat tumor biopsy and a repeat next-generation sequence analysis of the resistant tumor. The tumor still had the original HER2 mutation that was present there at diagnosis. There was not a new HER2 mutation to suggest a resistance mutation to cevabertinib identified, and the previously identified MTAP deletion was also still present there. So a similar genetic profile that was there at the time of pre-treatment with cevabertinib. And this is, of course, a very common scenario that we face in the clinic. And one of the next questions, of course, is what do we do with this? How does this help us or not help us in thinking about moving forward? Oops. So I'll turn to Dr. Lee to ask this question. Since you talked about the different therapies, and assuming all of these therapies are available, what would you be thinking about in terms of, I listed some options here about how you would approach treating this patient?
So this is really a relatively new challenge or question because zivobertinib as well as zongertinib only approved very recently, but this is inevitably we are going to face this. I'm glad that the patient had a repeat biopsy at the time of progression. That's the step one to understand that at that time what's the tumor status. I wouldn't, among those options, I wouldn't switch to zongertinib at this moment because I felt like those two drugs both have very similar potency, and if there's no additional mutation that's specifically fitting for zongertinib, I think the likelihood of this patient will respond to zongertinib after zivobertinib progression is quite low. If I'm choosing standard of care option, I think trastuzumab deruxtecan will be my first option. Although we don't know what's the response rate and the duration for patients who progress after TKI, although we know the reverse. But because of the MOAs are so different, so I will still anticipate at least 30-40% response for HER2 in this setting. So that will be my first top priority treatment option as a standard of care. As all three of us in major cancer centers, I think we all have clinical trials. This is not an uncommon scenario. I think Dr. Yang can comment on that. We detect a homogeneous deletion of the MTAP, so that opened the whole possibility of a PRMT5 inhibitor as a clinical trial. But I do also worry a little bit about monotherapy because it's a true, completely truncoclonal thing, or is a subclone that's selected after HER2 TKI. But evaluating for clinical trials from ADC to PRMT5 to other options, that will be also a group of discussion, a group of options I will discuss with this patient.
Wonderful, thank you. At this point, let's move on to some of the questions. And please submit questions online using the QR code on the screen or on the pamphlets that you find on your table. And we have a few questions that have emerged, and a lot of these are diagnostic questions. So I'll have Dr. Yang take the first crack at these. In a low-resource setting where comprehensive NGS panels are not universally available, what would you recommend as a pragmatic, stepwise diagnostic algorithm for detecting HER2 mutations in non-small cell lung cancer? Specifically, is there a validated role for initial IHC screening followed by targeted molecular confirmation, or should we prioritize limited gene panels even in constrained environments?
Yeah, that's a great question, and I think this question gets to, again, I wanted to highlight the fact that these biomarkers, HER2 mutations and HER2 overexpression are very distinct, and so you can't use IHC to screen for the mutations, and so that's just one thing I wanted to emphasize. And in sort of low resource settings, I think, and let's say that NGS is not possible, unfortunately, and all we have is maybe PCR assays that looks for just the most common mutations, maybe like the YVMSA mutation. So I think it is reasonable to employ screening with PCR assays, but understanding that a negative result in a PCR is not a true negative result for HER2 mutations, and so maybe incorporating some sort of a different strategy for the HER2 negative cases on PCR to do, send it out to NGS or maybe even Sanger sequencing to make sure that we're covering for all the HER2 mutations that can be detected. But IHC is separate, and again, you cannot use IHC to screen for the mutations.
Thank you. Next question asks about co-mutations with HER2. I think the question is, and let's take it in two parts. One is, do we ever see sort of compound heterozygote HER2 mutations where we have two different HER2 mutations in the same patient's tumor?
I mean, generally, no. I think in like the treatment naive setting, you usually typically just see one HER2 mutation, and they're, especially the exon 20 mutations are mutually exclusive with all the other sort of oncogenic drivers that we think about, like KRAS and EGFR. I have seen some of the rare sort of the extracellular domain mutations co-occur with some of the other oncogenes like EGFR, so that can occur in sort of rare instances, and that could be sort of an interesting situation. And then, of course, in the status post-treatment, especially on the TKIs, you could have secondary mutations that can arise as a mechanism of on-target resistance, which you would see secondary HER2 mutations along with your founder original mutation.
And maybe if you can also address, like in this patient, there was MTAP deletion, but what about other common mutations found in lung cancers like TP53 mutations?
Yeah, I mean, I've certainly seen some cases of p53 mutations co-occur with HER2 mutations. We can have MTAP deletion, CDKN2A deletion. So certainly, we can have a little bit more of different types of alterations that occur. But in terms of the major oncogenic drivers like KRAS and EGFR, BRAF, those are largely mutually exclusive with HER2 mutations.
Yeah, Pasi, I want to add a line here that in our landscape, 3,000 HER2 patients, we did see TP53 as the most common co-alteration. And in the zivabertinib manuscript, the team evaluated when the TP53 co-occur with HER2, those patients actually have a slightly inferior outcome with TKI. That's all consistent with what we know that in EGFR, in other mutation, TP53 mutation is not a helpful thing.
Yeah, usually associated with a slightly worse prognosis.
Yep.
And one more diagnostic question. Would you consider HER2 testing by FISH or IHC in any case without NGS testing?
So without NGS testing, well, I would recommend NGS testing to begin with to make sure that we cover all the actionable HER2 mutations. But I think with regards to HER2 FISH, like I mentioned before, there's currently no role for HER2 FISH in lung cancer. Right now, HER2 amplification, can be seen, but it's more of an investigational biomarker. So there's currently no, drugs approved for it. So technically, we don't really need to assess for HER2 amplification, specifically using FISH. Now, when you're doing NGS, if your assay is validated for amplification, you will see sometimes cases of HER2 amplification. But I would say that with regards to overexpression, 3+ and FISH, I think, those are very different biomarkers again. And the most common question I get, I think, is what do you do when you have 2+ IHC for HER2, right? Do you reflex it to FISH? And the answer right now is no. Right now, there's no role for doing FISH to investigate these equivocal cases.
And to echo what you mentioned during your talk was that the IHC approval for trastuzumab deruxtecan is only for 3+.
Exactly, yeah. It's only for 3+ using the gastric criteria.
Okay, question for Dr. Lee. If you have a patient with HER2 mutant lung cancer and CNS metastases, which TKI would you consider and why?
I think currently zangertinib is the only one have really CNS data out there with the CNS response rate in the 40% range. I will be very careful if it's truly very small asymptomatic brain metastasis. I might start zangertinib without adding radiation early because we don't have the same confidence of like osimertinib. We know they're CNS penetrating, so potentially can bypass radiation. Among those two TKI currently, the zangertinib is the only one having data.
Yeah, and I'll just add to that there is some data on trastuzumab deruxtecan in also treating patients who have CNS metastases. The response rate, obviously doing cross-trial comparisons, is a little bit less than what is seen with zangertinib, but both are options.
Right.
Another diagnostic question for Dr. Yang. Is there a need for reflex HER2 IHC testing in rebiopsies in progressing non-small cell lung cancer?
That's another great question, and I think it's sort of an evolving concept right now, especially in a lot of these major medical centers. What the NCCN guideline recommends currently is that, right now they recommend that IHC be available for all patients with non-small cell lung cancer. It doesn't make any strong statements about doing it reflexively on a particular scenario, but I think some centers are definitely thinking about doing HER2 IHC as part of the initial diagnostic workflow, along with the other first line and second line biomarkers. Whereas others, I think, are thinking of doing more of a ad hoc sort of approach where it's just clinician request driven. So if the patient is progressing, then maybe that's when we only do HER2 as well as CMET, because those are more for second line treatment. So I think you'll hear a lot more about these biomarkers, and I think we're gonna just need to do more research in figuring out what's the best strategy. But I think the most important thing is that we have an IHC assay that we can implement for our patients with non-small cell lung cancer.
I have a question for Dr. Lee. If our patient in this scenario would have had the extracellular domain HER2 mutation, the S310F, which is a very common one, how would you approach treating the patient with a HER2-directed therapy?
Yeah, so to me, that's almost a completely different treatment pathway. The two TKIs, their FDA approval is non-squam, non-small cell, and also have to be HER2 TKD domain. The approval comes with a reason, because the TKD domain patients have the response rate in the high 60 to 70. The non-TKD domain patients were evaluated in both BIMI and LUNG-01 and then SOHO-1. Their response rate is not as good. There are some responses, but very different, completely different. And then that's the data from the trial. And then if we think about the biology, the 310, I think that's extracellular, so that help with the dimerization, but doesn't impact the receptor. Therefore, I think a trastuzumab based approach make a lot more biological sense. In that particular patient, if it's a patient detected with S310F, I will go for trastuzumab deruxtecan as a second-line treatment.
Yes, I would agree with you there, and certainly in the trials that you showed, there are some patients who had the extracellular domain mutations who also responded to T-DXd. So there is some clinical data there, although the N, in terms of the number of patients that have been evaluated, it still is quite low.
Yeah, so Pasi, I just also want to make a comment that we're excited that we have two different options, two classes of options, but exactly how to serve each of the HER2 patients, I think still need ongoing understanding. Now they're approved, maybe we can have actually bigger patient cohort sets, right? So understanding not just the common mutations, some of the uncommon mutations that we detected, can the antibody-based approach benefit those patients? I think those are all research questions we'll have to move forward with.
And do you think there is any reason to evaluate the combination of an antibody-drug conjugate like T-DXd with a HER2 TKI?
I think so, because I think HER2 is ERBB2 and EGFR is ERBB1. We can learn so much from, you guys did 20 years of EGFR development. The combination now in the frontline EGFR treatment is standard of care. And then for HER2, I don't think it's unreasonable to combine with a cytotoxic agent, but exactly which one, the dosing, and how to avoid overlapping HER2 toxicity, those are all good questions.
Another treatment question. Do you consider the TKIs in treatment-naive patients based on the data and the FDA voucher?
I would if I have the access. I think because the data looks really, even the second line, I think the PFS and then duration of response is beyond 1 year. For the front line, we only expect better. And then for patients to be able to take oral medication once a day, manageable toxicity, that's really quite appealing.
And you mentioned we will start to see some data from the frontline trials, maybe this year or next year.
Yeah, so it's already published. The abstract title is published online, so ELCC will have an update.
Okay. So certainly more to come over this year as these trials mature and additional data evolves in this space. And as Dr. Lee mentioned, these aren't the ones that are approved aren't the only ones out there. There are additional new experimental HER2 targeted therapies that are out there. So this is continues to be an evolving field, and I wanted to thank our panelists and for all of you in person and online for participating today. Please, if you want to earn CME credit, scan the QR code or click on the link there. And I hope all of you have a good evening and enjoy the TTLC meeting. And thank you for coming.